different complexities and perspectives when thinking about scaling nutrition interventions. And many thanks to a few of you on the call right now and some working group members who have contributed and or authored some of the existing articles. This month in January, there will be a few more articles that will be published. And one of the articles we're hoping to actually be a compilation of input from working group members, specifically on your experiences and your challenges in your roles from your various organizations and your experience in the nutrition sector on challenges when trying to promote scaling up nutrition activities. So this is really an open invitation for any of you who may or may not, or may be interested in providing a quote. It could be on the record or off the record, or any type of contribution that would be compiled and synthesized together in one final article to close out the series. So if this is of interest to you, we ask that you please reach out to Malia, who is the reporter from DevEx, and she's asking to have folks reach out to her with interest by January 22nd, with hopes to publish the article by the end of the month. We think this is a really exciting opportunity for encouraging a broader conversation on scaling and nutrition, and we hope you take advantage of it. So if interested, please do reach out to Malia directly, and she'll take it from there. So moving forward now to the rest of the agenda, if we could get to the next slide, please. It's my great pleasure to introduce both of our presenters today. We've got two presentations that will each take about 15 minutes. And as Dylan mentioned, we'll have a fair amount of Q&A and open discussion time after both of the presentations. And we really hope that these presentations will help spark some interest to shed some light on some of the work that folks are doing on nutrition and scaling up already. So it's my great pleasure to introduce our first speaker, Dr. Stuart Gillespie, who is a senior research fellow from IFPRI, along with many other roles that he serves. He is an expert on scaling and has been thinking about complexities with scaling up nutrition impact over the years and has published extensively about it. So we're so pleased to have Stuart join us today and give us a presentation on scaling up impact on nutrition. What will it take? So over to you, Stuart.
Great, thank you. Thank you very much, Chaitanya and Dylan, for the opportunity. Yeah, so I'm going to try and spin through quite a few slides. Some of them will take longer than others. The focus is, as you see, on scaling up impact, and a particular emphasis on the word impact. It's not about necessarily scaling up any one single intervention, which we'll come to. Next slide, please. Okay, so and actually could you go back one slide, please? Yeah, that's the one rationale. So we really started looking systematically at the issue and the challenge of scaling when we, colleagues of mine, were involved in developing a paper for the 2013 Lancet series. It was actually paper 4 on the politics of reducing malnutrition. And we felt there was a bit of a gap there in terms of defining scaling up. It's a buzzword. It was almost a mantra in the nutrition field, although it didn't really exist in the 20th century. It's really in the last 20 years or so that it's had a lot of traction. But to actually begin to try and understand it and to characterize it and to understand what drives successful scaling. And the background to this, as you know, is over the last 10 years, there's been a significant momentum in terms of generating interest and a level of commitment to address malnutrition, or particularly undernutrition, moving increasingly towards malnutrition. Sun Movement, Nutrition for Growth summits, one this year. There have been 2 Lancet series, well as one also on other commission. There's a commission on the syndemic and the recent one on double burden, released just at the end of last year. There may be one also, a mini series coming out this year. Global nutrition reports, many political and policy statements, global, national. We have, of course, the Agenda 2030 and the SDGs. That's the aspiration, that's momentum. That's, if you like, the attention and the high level commitment that has been espoused to address nutrition. And then we see the realities. And if we look at the different levels of action, we see continuing gaps in terms of coverage of and high quality nutrition interventions or nutrition specific interventions. Where they're most needed, they tend to be less likely to exist. We see continuing challenges around the enhancing nutritionist sensitivity of various sectoral programs, and we see a gap between political attention and actual system commitment, which we'll come to later on. Next slide, please. So, question is, what are we talking about? Are we talking about making something bigger, and/or is it about generating greater impact? Next slide. It can also be potentially about change. Something may change as it goes from small to a larger scale. It may need to change. Next slide. And relatedly, it could be about evolution. I'm a cyclist, which is why I put the last one on. But things will change, they'll evolve, they may look very different and may need to look very different as we go from a smaller scale to a larger scale. Next slide, please. So the first part of the two parts of this presentation relates to work we did after that Lancet series, when we set about with colleagues Panima Menon, Andrew Kennedy, to do a systematic review of scaling up impact. And next slide, please. The objective of that review was not only to look at nutrition, but also to look at other disciplines, plugging in various keywords to distill critical elements to guide actions that focus on scaling up impact on nutrition. Next slide. And the guidance, and we were guided by the Lancet framework in as much as we recognized the need for immediate or more direct nutrition specific actions, nutrition sensitive policies and programs in a context of an enabling environment that relates to policy, politics, and financing and capacity. So that was the framing of this. We saw it as important to focus upstream on impact, and therefore various actions that relate to that. So the definition of scaling up nutrition for us was a process aimed at maximizing the reach and effectiveness of a range of nutrition relevant actions, leading to sustained impact on nutrition outcomes. Next slide, please. And I'm not going to go into detail on the methods. It was a systematic literature search. We plugged in the keywords that are listed out here. So we were looking beyond nutrition to also health, agriculture, development. We looked at two very comprehensive bibliographies, as well as those databases. We also consulted with key experts in a kind of snowballing approach, condensing to 42 papers, 24 of which focused on and included theoretical frameworks, 18 on program experiences, and there was a bit of overlap between those two. And out of that search, or following that search, we developed a long list of key elements, processes, features that were seen to be important in this review. They were later condensed to 9 key elements, which I will describe briefly. Now, in addition to that broader systematic review, we did 4 in-depth case studies that related to 2 nutrition-specific initiatives, one focusing on IFA supplementation in Nepal, one was relating to the work done by Alive and Thrive. We looked at 2 nutrition-sensitive programs, Progressor in Mexico and Homestead Food Production in Bangladesh. So there were 9 drivers. Next slide, please. And thanks, this is number 1, vision. So just to preface this by saying that obviously not every single one of these 9 are required to generate a significant impact on nutrition. In most cases, we found most of these drivers to be in place and at a reasonable level of of quality and integrity in the more successful initiatives. So the first relates to vision, and the question is, where are we going? And this often, surprisingly, is not clearly articulated in many cases. It is obviously, pretty obviously important. As part of that, I think, and we found it to be important to be specific about indicators of impact and success. The vision will determine these metrics. The goal will determine the metrics, and will be crucially important for accountability. Number 2, please. Next slide. The second is the question of what is actually being scaled. Are we talking about scaling an intervention? Are we talking about a process, a principle, technology, an innovation, or a methodology? And it could be several of these. And then there are questions related to that about, is there already some evidence of efficacy at a smaller scale? Do we have some evidence of large-scale effectiveness, or had those programs actually had some of that evidence before they set out to scale? And some of these factors here, I'm going to talk about key questions that were addressed by some of these initiatives. And one is clearly that whatever works at a small scale may not work when it is at a large scale, regardless of what kind of process to get to that large scale. It may need to look different. The context may change, the intervention may change. And different interventions will differ with regard to their scalability. And we highlight some of those kind of issues relating, or those components of scalability, if you like, or questions to be addressed in thinking about that below in these last few points here. Number 3, next slide, please. Under what conditions? This relates very much to, if you like, the enabling environment, and that could be economic, social, cultural, political. There are questions about institutional arrangements. We need to think about community and household contexts. We need to think about implementation contexts. Some of these projects are standalone, some are more integrated. That will affect their potential for scaling, and it may affect the various factors that need to come into play within that scaling process. Number 4, please, next slide. And there are inevitably positives and negatives in terms of the attempt or the process of scaling. Some of these are catalytic. They may be positive drivers. Some may be negative. They may actually be roadblocks or obstacles or barriers, and some may be internal to the project or the whatever is being scaled. Some may be external factors that are outside the control of the program manager. There we need to really look at actors and stakeholders, and we found leadership, often the individual leadership, to be pivotal in successful scaling. It's over time, and this relates to sustainability, government ownership being particularly important. And so again, there are incentives that can be built into job descriptions, that can be built into the metrics for accountability, which will be positive, and there may be certain disincentives that act as barriers. Next slide, please. So, and this is actually the middle of the 9, and this is literally pivotal to the whole discussion. It's about the process. So it's going from, it's more than what will be done, it's going to be about how it will be done in terms of the process of scaling. And we built upon the work of Peter Ruvin from 20 years ago, excellent paper that differentiated 4 particular types of process and pathway, one relating to the normal image of scaling as making something bigger or quantitative, that would relate to scaling out of an intervention or a program. There's a functional pathway, which may involve changes in activities that are done, linking with other activities, integrating more with other activities as you grow. There is a political element or dimension that goes from, if you like, more of a handout type program to one in which empowerment is built in more systematically. And then there's the organizational aspect that relates very much to capacity to scale and capacity to implement at large scale. So those 4 pathways are key to pay attention to. Some of them will be simultaneous, some may be more sequential. Some of them have to be purposefully driven by those involved, and some may emerge. Next slide, please, number 6. Capacity is obviously key, and that can be individual level, organizational, community should be there, systemic. And there are different types of capacities for different purposes. Obviously, strategic is about operating in complex environments and complex systems. Operational is maybe more specific about implementation and getting the job done. And we do find often where capacities have been neglected, either in it being not assessed or analysed or actually being strengthened, we do find that there tends to be an association with poor quality scaling and a lack of impact at large scale of different programs. Number 7, next slide, please. Governance key, obviously, and here we're talking about structures and systems that underpin these processes. And I'm going to differentiate the horizontal and vertical. Horizontal, and we know this from working in nutrition being multi-sectoral, it requires cross-sectoral engagement and collaboration. That is, if you like, the horizontal element or dimension of it. And there is also vertical, from national down to local. So the translation of national policies into district level programs and actions and onwards down to community level. Those two axes, horizontal and vertical, need to be as optimal as possible and work in as to be as coherent as possible. Scaling down is a very important term, really, and it relates to decentralization of power, of resources, of responsibility, and often that's required for sustainable scale up of impact. So we should remember and pay attention to that. Number 8, please, next slide. Oh yeah, and then actually this is an important aspect of governance, that we inevitably run into trade-offs or challenges where decisions and tensions, if you like, where decisions will need to be made. Now, one relates to, it's often easy to do something to reach a certain scale, but that might not be the right thing to do. And we see, so there's that tension about doing the easy thing versus doing the important thing, and reaching the in-reach is always going to be difficult. There's a tension often between speed, moving something fast, and sustainability, where it's been embedded and grounded and is likely to last longer. And one that I was particularly aware of working in India was when we were working on the ICDS program. It was pushing out the ICDS fast in terms of getting wide coverage, and this is a politically driven move in the 90s. The quantity, if you like, or the coverage was there on paper, but the quality in terms of implementation was not. So there's that quality-quantity sort of dichotomy or challenge that needs to be addressed. Next slide, please. Finance is key. I will spin through some of this, you know this, but the elements there we found to be important were adequacy, stability, flexibility. We need to continue to understand costs of what's required in terms of other actions outside of our nutrition-specific domains. Next slide, please. This last driver relates to M&E, and there and knowledge and learning and accountability. They tend to come together. We need to actually always strive for better evaluations of scaling and of large-scale programs, and in that process to highlight impact pathways and to strengthen the capacity to do rigorous and high quality M&E. As part of that, we will have an implementation research as well as part of that. That will be key for learning ultimately. So the 9 factors are here.
Unknown participant is now joining.
If you go to the next slide, I think it's the next slide is the diagram. Yep, there it is. Okay, terribly complex, but and I won't spend too much time because I've already talked about it. But that is, in a sense, putting it all together, starting with a set of evidence-based nutrition relevant actions at the base, if you can see that, various drivers relating to processes, 4 different types, to hopefully quality implementation at scale, and on to which requires strong governance systems, which requires strong focus on capacity, and then the feedback loop through M&E. And then the two arrows on either side, one relates to the need to think in terms of timeline, the other in terms of ownership of the process. So that's, if you like, the theory of change. I need to speed up, so I'm going to the next slide, please. Right, this is a much shorter second part. So we did the systematic review. We then said, okay, we need to understand what's going on in countries that have been relatively successful for their economic growth in terms of driving down rates of child stunting. So we initiated through the Transform Nutrition Initiative that I led starting several years ago. We developed an initiative called Stories of Change, which is still ongoing, actually, in 2015. Next slide, please. And the objectives were, in this case, to look at real-world experience at scale in those countries, to understand drivers, pathways, and challenges right the way across the board, from generating commitment to turning that or modifying policies and programs, and then turning that into effective implementation at scale. To understand the quantitative and the qualitative aspects of that, but also crucially, to use this to kind of inform, but also to inspire, to show what is possible in countries to improve nutrition at scale. Next slide, please. And these are the countries. There were 3 waves. The third wave is underway right now. The first 2 waves related to stunting. Most of that has been completed. We are writing that up for a Lancet paper that will be coming out by July. And then the third wave is looking more at double burden issues in those countries where that's an issue. Next slide, please. And the methods, briefly: literature review, landscaping of policies, stakeholder mapping of key individuals or organizations. And then 2 types of analysis. One is quantitative, which I'll talk about in a second. One is mixed methods, where we undertake key informant interviews at every level, from community level. I think we did over 400 community level interviews with mothers, with frontline workers, right away up to national level policymakers, and various focus group discussions, stakeholder consultations, learning events, and so on. Next slide, please. So with regard to the quantitative analysis, this is one example. I'm not going to give you, I'm just going to summarize the way this was done. It was a decomposition analysis of repeated DHS data sets, whereby, and I didn't really get involved in this because I don't know how to do it, but our colleagues at Derek Heady in particular was involved in analysis that identified those drivers at underlying level for which there were data within DHS data sets that were particularly linked to child stunting declines in countries, and the rate at which those drivers were moving over time in these repeat surveys. And putting that together, it's possible to attribute a certain percentage of the improvement to the different drivers, and that's what we've done in all these different countries. There will be an unexplained portion for which we do not have the data to say, what was involved in that unexplained portion. But for what we can say, which tend to be up to about 60–70% of change, we can capture that through the DHS data. And this is an example. Nepal is in the inner circle, Bangladesh in the outer circle, of the types of factors that were found to be important in these 2 countries. That's the quantitative side of what we were doing. Next slide, please. And then the qualitative, I'm going to sum up in those 7 factors. Now, these are, and I'm running out of time, so I won't spend more time on this. Some of these, and it's fortunate that this was the case, some of these most of these actually are overlapping with what I've shown in terms of the 9 drivers that we found from the systematic review. But they're slightly nuanced in different ways, and the devil very much is in the detail in these country case studies. Commitment, different forms that we showed, from going from political attention to policy commitment to system commitment, whereby job descriptions start to change, and a financial commitment that goes along with that. Coherence, as I mentioned, horizontally and vertically, and so on and so forth. Next slide, please. Okay, this is the last, I think, about the last slide. So these, just to highlight where this material is available. We wrote a book, Nourishing Millions, pulling together. This was actually not directly on the case studies, but it was drawing on the literature of relative success in different types of interventions over a 50-year period. On the right, the Global Food Security Special Issues came out in 2017, captures those 6 case studies, but various other synthesis papers. And then we have audio visuals, we have briefs and various things online if you search for stories in change in nutrition. Next slide. Oh, here's the last slide. Yeah, so thank you very much. That was a kind of whistle-stop tour through 2 initiatives over the last 5 or 6 years. Happy to take questions at any time. Thank you.
Thank you so much, Stuart. Definitely synthesized a lot of effort on these 2 bits of work here, which are very helpful in terms of broad framing of some of the issues that we have all been talking about when thinking about scaling. In the interest of time, I think we should go ahead and just dive straight into our next presentation. And just to flag that we will have a fair bit of time, about 30 minutes for Q&A after Alison's presentation. So please do note down any questions that you have while Stuart's presentation is fresh in your mind, and we'll hopefully have plenty of time to go through all of your questions after the next presentation. So moving on to our second presenter, it's my pleasure to introduce to you all Alison Gregg, who is Technical Director of Global Technical Services at Nutrition International. And in her role, she has been leading on the global effort for scale up vitamin A supplementation. So I think this presentation will be a nice concrete way to root down some of the principles and drivers that Stuart just mentioned in the example of vitamin A supplementation. So handing it over to you, Alison.
Great. Well, thank you very much. I hope that everyone can hear me okay. So thanks, Stuart, for the overview. I think, I was asked to present on this scale-up story of vitamin A supplementation, and that for those of you who may know me, I've been working in vitamin A supplementation at the global level and supporting countries over the last roughly 20 years. And so it actually is rather difficult for me to very briefly, in a couple of minutes, 10 minutes, talk about the scale-up story of vitamin A supplementation. And so I have to say this was quite a challenge to try to distill it into some of these sort of key and salient points. And so I'm really coming at this, overarching from the global level, and just to highlight some of the key things that I think have emerged at it when we sort of look back retrospectively over time. And I'll try to bring up a few points along the way. And the aim here is really just to spark more discussion more than anything else. And so we'll hopefully leaving time for some conversation by the participants. So, as one does when starting to tackle a topic, I did this sort of thinking, okay, what is the story at scale? And immediately asked myself the question, is vitamin A supplementation at scale globally? What does this mean? I mean, these are some of the things that Stuart was alluding to as well, is really taking a very analytical look and saying, what do we mean by scale? Are we talking about, I think some of the terminologies was scaling out. Are we talking about coverage and reach? Are we talking about its sustained intervention? Is it truly scaled up within health systems? If we look at it in 2020 across the world, are policies in place, guidelines, health workers trained, supply chains, including VAS? I think we can say all of the answers to that is a yes, but there's several components that are still to do. And then that last piece being is the intended impact being realized? There is an observed contribution to the reduction in U5MR over the last 10 years. But, in today's environment, of course, we are also looking critically about, these assumptions around where the efficacy data came from. And there's healthy debates about the effectiveness in today's epidemiological context. Is the effect size the same as what was observed in the clinical trials in the 80s, 70s, and 80s? And So that debate we're not going to talk about today, but isn't so much a debate about the quality of the coverage at scale, but instead about the evidence base and its sort of more of its application to the current public health settings. So I thought that, just to get on a page for those of you who aren't as immersed in VAS as I am, that overall, this plot it plots the global two-dose coverage among children 6 to 59 months over time. This particular chart shows it between 2001 and 2017. The source of this data being UNICEF State of the World's Children, who collects this data on an annual basis. And what we see, there's a program. I mean, there's a vision and goal for impact of all children in settings with vitamin A deficiency being reached with vitamin A supplementation twice a year, implying 100% coverage is our goal. There's a program coverage target of aiming at greater than 80% with an assumed effectiveness on a population scale. And so when we look at this graph over time, we do see that on global averages, we aren't really quite at where we thought we would be at this point in time. This, I did want to just flip up saying, that looking at, behind global averages, there are, of course, regional variations in coverage. So this bar plot is really just saying, looking at, the bar, I'm not sure if the colors are coming through on your screens very well, but the far right bar in each of these categories is the year 2017, and each of these clusters of bars is a region. It's just showing that, for instance, in 2017 in West Africa, two-dose coverage is estimated at about 50%, whereas it's about 70% in East Asia and the Pacific. So looking at a global average of 62% at 2017, there is variation. And then, of course, behind all regional averages, there's wide variation between countries. I thought to try to tie the presentations together, I would try to use this very helpful framework presented by Stuart to walk through some of the key moments and what we might call some of the moments in sort of the history of VAS scale-up. And so, Stuart, if you don't mind, I will borrow your 9 elements to just try to highlight a few things and try to put some details into a global perspective of where VAS fits. The first 3 I found naturally sort of wanting to cluster them together around, for VAS, did we have a clear vision and goal where we're going, what is being scaled, and then the context and the enabling environment. Retrospectively, if we think about it over time, the vision and the goal.
Unknown participant is now exiting.
Began. Vitamin A supplementation began as an intervention to control blindness that was caused by severe vitamin A deficiency. In the mid 80s, WHO had clearly laid out the plan of action for prevention and control of VAD, and that included, sorry, there's an edit here, sorry, and vitamin A deficiency and xerophthalmia, and that plan of action included long, medium, and short-term measures. So as we know, the long-term measures is overall, change in diet, so that vitamin A intake of the population increases over time, and sort of the long and medium being food systems, access to vitamin A-rich foods, fortification of products, etc. And vitamin A supplementation was named as a short-term measure to provide protection, while the other more sustainable ways of addressing deficiency were scaled up. By the late 1980s, the links between vitamin A deficiency and increased mortality were being made. These were observed in some clinical trials, and in 1993, the seminal publication that really started that active shift was the Beaton et al. Meta-analyses that indicated, in populations where vitamin A deficiency was very high, and child mortality was very high, that there was a potential reduction in reduction in mortality among children by up to 23%. This shifted by the mid-90s, the global dialogue really began on the child survival role of VAS for infants and young children in high mortality setting. and sparked the urgent need to scale up VAS in those countries. So this was a shift where vitamin A supplementation, the vision and goal, was about as one piece of a Band-Aid approach to addressing the vitamin A deficiency problem that was across the developing world. And then the vision and goal did take a shift as it went towards the role that vitamin A supplementation could play in reducing mortality. Throughout that, in the mid 90s, the clear intervention was there. A lot of evidence. I won't dwell on that, but a lot of evidence was coming together. WHO issued very clear guidelines for high dose supplementation in '97, and proceeded to confirm those in 2011. The context overall was that really did drive the acceleration around vitamin A supplementation. I think we can attribute a lot of it to the where coverage, vitamin A supplementation was identified as a child survival intervention, and where the MDGs began. The VAS coverage was informally adopted as an additional sort of core immediate indicator of progress towards MDG 1, and in addition, an additional optional indicator of progress towards MDG 4. And through this process was formally identified as a key part of what was being called the arsenal of effective interventions against childhood killers. So during this time, almost 80 countries around the world where vitamin A deficiency was a public health problem had vitamin A deficiency reduction strategies that included VAS as a key intervention for children as part of a suite of interventions to address deficiency. But then around the 2000s, around the spark of the MDGs, that's when we did start to see a shift where countries were also developing strategies and policies around child survival, and that vitamin A supplementation was an intervention that was also part of child survival policies and MDG planning and accountability for countries. So going back to this global graph, this just to highlight where we were at that point, the policies and guidelines and commitment was all scaling up, but coverage of 2 doses of vitamin A supplementation from a coverage point of view was certainly not scaling up. At least 1 dose was 59% globally, and coverage of children with 2 doses was as low as 36%. Coming back to the key elements, as Stuart did point out, is saying really this key element number 5, this strategy, process, and pathway, and I would say that also the capacity to scale it up within that process and pathway is incredibly key. Here, in the history of how VAS was scaled up, this was the pathway to scale was determined to be through campaigns. In 1998, WHO and UNICEF made the recommendation to include vitamin A supplementation in polio NIDS campaigns that were reaching, huge amounts of children. There was very large resources going in the efforts to eradicate polio, and asking ourselves the question that if we can reach all children through the polio platform, this small addition of including a vitamin A supplement at the time of giving the polio vaccine should be a quick way to scale things up. That really was the beginning of the campaign approach, and certainly never intended to be the long-term solution. By 2004, so really, between 1998 and 2004, there was the first indications that the first waves of polio NIDS were beginning to in fact be scaled down as polio became, as the vaccination efforts became more successful. Around that time, there was a very large effort, by UNICEF and Micronutrient Initiative at the time, with Canadian support. We carried out a bottleneck analysis across 21 countries across South Asia, Middle East, and Sub-Saharan Africa. and to identify common bottlenecks across countries and areas of best practice as countries were looking at this initial sort of what we were thinking even at that time. We have a post-NIDS strategy problem on our hands where the polio platform is disappearing and we need something to replace it. This assessment was done over time. It informed recommendations on how to transition from polio NIDS to more of a health systems approach. And in those days as well, the strengths of the health system were variable across many countries. And some of the recommendations led us to recommending around the biannual child health days. And this was where they began to be recommended and established to deliver an integrated package of preventive child health services with vitamin A supplementation as its cornerstone. So this really wasn't the recommendation, and the thinking around this was really not so much that it would be the same vertical campaign, but we're calling them child health days instead of a polio campaign, but instead that it was an extension of the health service where it was all preventive services for children that got extended out using a biannual campaign approach and or a quarterly approach. And it was intended to have the health system at the core. This graphic, again, I'm not sure if it comes through that well on the screen, hard to see the specifics, but very broadly, the orange bars along the bottom are the number of VAS delivery events that were done through polio campaigns between the years of 2000 on the left and 2013 on the right. The blue bars in the next one up, the blue bars are those delivered by child health days. So just very broadly, what this shows is that in 2000, the very far left bar, the stacked bar, showed that by
Unknown participant is now joining.
By delivery platform, it was roughly evenly distributed, very roughly, of course. And then by the mid-2000s, the campaigns, the combination of the orange bar and the blue bar, became the main, more than half of the delivery events were through campaign. But the flip that happened in the mid-2000s was between polio and child health days. We could spend an entire day on discussing delivery platforms, and so I really won't go into much more detail than that. But there is, behind all of these examples, there is enormous amount of depth that I think warrants, a lot more deeper thinking and presentation. So I apologize for sort of skimming over some of these big things, but just in the sake of time, I wanted to point out another sort of major event in the Scale Up for VAS, which was around the barriers. Certainly this was around the access to supply. So the very rapid increased demand for coverage in the late 90s drove the increased need for supplies of high quality vitamin A capsules. The high dose capsules were not readily available. There's no other.
Is now exiting.
There's no other commercial market for them, and so really there was a very large risk of supply blocking the scale up, and few manufacturers globally. The government of Canada here played an integral role in addressing the gap through direct support to MI in 1998 to carry out and take action on a centralized procurement and established a global vitamin A capsule donation program. And this came with a very long-term funding commitment from Canada. It's now been, we're coming to almost 20 years. So this was a very integral part of a lifting of a barrier that really, this is a supplementation program. Without the supplement, you have no scale up. So this was certainly something that was one of the main things that was lifted. There's a lot of dimensions to this global capsule program and the donation program. And again, this could be an entire presentation on the pros and cons and the effects of this and where we are now, et cetera. And, you know, there's so many details here, and I won't bore everyone with this, but we did have, you know, at the time in a donor environment where tide aid was a policy, and this actually it affected the way that we were able to procure capsules, and it affected the way the market developed. So Canadian manufacturers became the first ones to develop these capsules to the quality at the sort of international level. That did change over time, and we have expanded, you know, much more around the market shaping, as well as bringing other manufacturers on board, working with WHO and the
Unknown participant is
U.S.
now
Pharmacopoeia,
exiting.
the U.S. Pharmacopoeias, et cetera, to develop standards for international procurement to broaden the market. And just a quick map around how, when this did begin, almost 80 countries were receiving donated supply for their programs, and that over time, countries are beginning to be able to procure, put budget to, and have the capacity to do their tender and procurement on their own. So in really quick summary, I thought I would try to identify, if we can, some reflection of lessons learned. One of the big things that did make a huge difference around the scale up for vitamin A supplementation was really this issue of global coordination and consensus. It was at the time, and it certainly does. It continues to be a key even today. IVAG was some of the early groups that were bringing academic partners and sort of policy and program people together to get consensus on the evidence and the way forward. Certainly, you know, with WHO and others, the regulatory frameworks, et cetera. And this has continued in the vitamin A space around, you know, with other groups like what I chair, the Global Alliance for Vitamin A, and its many partners. Remaining very committed to convening and consensus building to provide, you know, guidance to countries, translating global recommendations as set out by WHO, but more importantly, bringing countries together to share experiences and lessons learned. And so I think Stuart pointed out at the end of his presentation around the importance of implementation science, evaluation, the data, and lessons learned, best practices to scale, that the learning as you're doing certainly has been a big part of the scale up of vitamin A supplementation, and a very regular, certainly in sub-Saharan Africa, regular bringing together of multiple countries to share experiences and try to address some of the operational problems that are happening at the country level. Certainly cannot underscore the sustained financial commitment from Canada that has been one of the key success factors. This is, you know, you can
Unknown participant is now exiting.
Difficult to separate the history of vitamin A supplementation and child survival from the financial commitment that the government of Canada has made. Of course, they're not the only donor who has, but they really have showed an enormous amount of leadership in this place. As well, the the time to full scale is very long. This is it's one of the things that makes the vitamin A supplementation story difficult to talk about, is that those who aren't immersed in it look at it and say, "My God, are we still doing this? This, you know, this started in the 90s. Why are we still supplementing? Why is it still needed? And why are we still talking about it?" You know, again, that's a whole other story, but this an acknowledgement that scale up done properly, done well, et cetera, is not a short-term 5-year grant. To bring from evidence to efficacy to effectiveness and to scale and sustainability. It's a long road. Through the history, a lot of lessons learned about the trade-offs. A lot of trade-offs were made to initiate scale up using vertical campaigns, as we sort of touched on, versus routine health systems. This wasn't done blindly. It was done out of an urgency, feeling compelled to address and support child survival efforts in countries and the MDGs. I guess just, there's a lot of work going on. It's continuing. It started in 2004, and then really more actively since 2010, And I and many GAVA partners, UNICEF and HKI and others, have been systematically supporting country by country the integration of VAS into their very unique routine health systems. It's slow going, and this can only be done in countries where health systems is strong enough, and or they have a very large investment in the health system strengthening. Here I think where we're seeing a lot of work that at the global and regional level is the emphasis on UHC is really strengthening this as well. Of course, there's still remains a lot of countries where campaigns are still needed. The shift from donor support for these campaigns to public financing requires a lot of intensive and sustained advocacy. And these are countries where we know that the highest numbers of deaths of children are happening, where vitamin A deficiency is still quite severe. And unfortunately, these are the places where health systems are not reaching a lot of children with preventive services. And this is where we're seeing some critical drop in coverage. I think UNICEF published a few reports on exactly this to this point, and this really is a global sort of rallying call where the vitamin A world is really talking again about, are we at scale? What can we do for these settings? And then very lastly, we couldn't really talk about scaling up VAS without talking about that right now there are a few countries that are actually faced with the challenge, but also the opportunity of scaling back VAS, where vitamin A deficiency appears to be being reduced in the population, meaning that food systems and other ways of reducing deficiency, infection control, et cetera, is improving, and so we are seeing less need for a universal supplementation approach. This has, again, it's a whole other topic of conversation, but here what we're seeing is that the evidence and the quality of data that was needed in the 90s to initiate VAS in a country is not the same quality of evidence and the detail that one needs now when looking at to inform us of when is it safe to scale back VAS in the population. I think one of Stuart's slides had pointed out the very important part about the monitoring for the impact you think you are having. And here is one where vitamin A supplementation is intended to be in the context of other efforts to increase vitamin A intake in the population, but yet we have very little data around either the vitamin A status of children and or the sources of vitamin A in the diet. And so the challenge around can we safely remove supplementation from a mix of interventions is increasingly difficult. So I will thank you. I'll stop there, and I look forward to, I guess, if we have time for questions.
Yes, thank you so much, Allison. Really fascinating presentation, and you were able to synthesize a lot in a short amount of time. So thank you so much. And now we're really excited to open up the floor to not just Q&A, but really hope to have a lot of rich discussion, comments, reactions, and thoughts to both Allison and Stuart's presentation. And so let's see how this works on this platform. But let's go ahead and try that. If you do have a question, to go ahead and unmute yourself, introduce yourself, and pose your comment or question. So the floor is now open.
Hello, this is Homero Martinez from Nutrition International.
Unknown participant is now exiting.
I have a comment for Stuart. I wanted to ask, well, first comment, I think it is very inspiring to see this compilation of what works in scaling up. My question was whether there has been an effort to compile what did not work and why didn't it work. And I think it will help us to shape up lessons learned. Thank you.
And Stuart, before you answer that question, just to make a quick note that for those that don't want to verbally ask their question or comment, feel free to use the chat box and I'll read your questions out. So over to you, Stuart.
Great, thanks. Yeah, that's an excellent question. And the short answer, well, at least I haven't been directly involved in capturing failure factors systematically, but I do think it's important to understand failure. I think it was Urban Johnson of UNICEF who once said, you can learn from success, you can learn from failure, you tend to learn faster from success, but failure's far more common. So yeah, I think it's important. And actually, when we undertook our stories of change case studies, the last wave we called stories of challenge, because we recognized, well, partly the fact in this case was that we didn't have a lot of positive change with regard to overweight and obesity, or pretty much nothing that we could find. So it was more about understanding the challenge of addressing the malnutrition across all its forms. And in both cases, in the earlier case studies, we looked at both change and challenge, and they're quite similar words, obviously, but they're looking at different aspects. So I totally agree with you. It's important to be honest and capture failure or limited success, however you want to call it, because we need to learn from everything, every type of experience. In fact, thanks.
Hello, this is Helen Coonan from Malaria Consortium. I wonder if you can hear me.
Yes, we can hear you.
Fantastic. Thank you both for the very interesting presentations. I just wanted maybe to share some work that we're doing in response to Alison's presentation. Malaria Consortium implements a mass drug administration strategy called Seasonal Malaria Chemo Prevention in the Sahel regions in 3 countries, including northern Nigeria. And for those unfamiliar, that's where you provide antimalarials to children under 5 during the seasonal, the rainy season when malaria is most prevalent. And just to share that in northern Nigeria this year, 2019 season, we added distribution of vitamin A in 2 of the LGAs in Sokoto State, and we're just collecting and starting the data analysis. We did obviously quantitative to assess the coverage and also qualitative on acceptability, etc. Unfortunately, I don't have much to say in terms of the results because we are just analysing it, although it was very well accepted and seemed to improve coverage. But we'd be very, very happy to keep the group updated on how that went.
Yes, Helen, please do keep us updated. We'd be eager to hear how that went. Questions and comments from others? And just to note that you're welcome to pose any questions in the chat box if you have them. But I actually do have a question myself, and I'll just selfishly take this time to pose it if that's all right. And it kind of is sparked by what Helen just flagged, and the idea of coupling one approach or intervention or our program onto another, and thinking about different ways of delivery platform. And so I guess my question is maybe towards Alison, but also to Stuart in terms of the cost and benefit of using different platforms.
Unknown participant is now
that may
exiting.
be strong at the time. For example, the polio vaccination campaigns, and using that as a leveraging that delivery platform, but the unintended potential risks that exposes yourself to, and thinking about scaling if you're using a platform that may potentially become less relevant or less robust over time. So looking back, Alison, I'm curious if you think that there should have been kind of a different way go about of starting up vitamin A supplementation other than leveraging the work that was already being done on polio.
Yeah, I mean, this is, a very sort of important thing to look at, because this is the trade-off, and this is it's short-term gain, long-term loss. That kind of look at things about this. But when we're looking at, it's different if we apply to other interventions. I think it's a hard question to ask if we're applying the vitamin A supplementation context to sort of the broader nutrition landscape, because a vitamin A supplement is really intended to protect a child who's vulnerable to infection and morbidity and mortality. And so in a way, that waiting, giving up an opportunity to reach a vulnerable child with a life-saving dose is a hard thing to give up, because you're thinking that in 10 years' time you may regret the platform not being there. And so this is a really challenging debate or way to, a philosophical, conversation around scale up, when you look at vitamin A supplementation, because it's in so many ways the sustainability, health system strengthening imperative gets trumped a bit by the importance of reaching vulnerable children. I think where this is what been the learning over time is that there is no, it isn't all or nothing, and that there's always a need to build systems as you go. The important part here is around not wasting resources. If you're already reaching the child some way else, you don't want to reach them again. But here you need robust monitoring systems. Over time, the importance of the use of the dose being recorded on the child health card was a lot of efforts at country level and even at district level, et cetera. And we're still working on this, is really trying to capture child-centered tracking of, did this individual child get a vitamin A supplement? Did they get it when they, for instance, were reached by the Mass Drug Administration that came through their community for malaria? And if they did, then that dose would be written on the card. So when they showed up at the health post for a routine immunization, or perhaps with the family for a wellness visit, that the child doesn't get it again. So there's so many program elements that have to be in place that I don't think you can say, don't take the opportunity to reach, but it has to be, it has to be within a certain context. I don't know if that helps.
It really does. It's not so black and white. Others?
Hi, it's Marie from ENN. Can you hear me?
Yes, Marie, go ahead.
Great, thank you. Thanks for two very great and really interesting presentations. It's a question, perhaps to Stuart, or indeed anyone on the call. I was wondering if there's been any review of how many nutrition intervention pilots have remained as such and never gone to scale, either because they didn't have ambitions for scale, or they didn't really factor in those considerations to move towards scale, or attempted and had barriers. Because at ENN and through our publication, particularly in Field Exchange, we see so many pilots and of nutrition interventions in small scale that really haven't been thinking about how they might scale up and transition to something more sustainable. And I'm just wondering, it would be very interesting to examine that and also look at what are the opportunity and resource costs of really not considering these facilitating factors that you've outlined for scale, and what price are we paying by not considering these.
Maybe Stuart here, maybe I could respond. I think it's a great question, Marie, and I don't know what the answer is. I think it's thousands upon thousands of programs that have remained at small scale. Now, some probably never really set out to scale up. Some may have tried but not figured out how to do it. Yeah, and I think it is, and obviously if you can look at nutrition specific, you can widen that and look at attempts at reaching scale through other routes. But it is a big issue with these kind of boutique projects that they may have an impact on a small scale. Now, you could argue if let 1,000 flowers bloom, so that if you have a system that is generating innovation and lots of small scale stuff over a wide area, then maybe that's okay. But I think part of this is also important in terms of linking with the biggest development agency there is, which is usually the government, or should be, and how to mainstream or have stronger connections with government policy and programming. So, but I think it's an important issue and a big challenge still. Thanks.
Thank you.
Would others on the call either like to respond to Marie's point and Stuart's response, or pose any other questions or comments? Anyone's most welcome to jump in. I know it's hard when we're on a virtual call to engage in discussion, but open to anyone.
Hi there, this is Nikki at ECF. I've got a question, if you can hear me okay.
Yes, go ahead.
Great, thank you. And I think it's a question really for both of you, and thank you both for the great presentations. First off, really interesting. I think a lot of what we struggle with in the nutrition world is how we are often piggybacking on onto the health system that's existing in the countries that we work in, and obviously there's often a lot of gaps in those health systems, weak infrastructure, HR gaps, and so on. And I just wondered what your perspective was on how we can move forward and effectively scale nutrition programs when we are dealing with such a weak system often in terms of the health system. And that's sort of the platform we have to work with. So somewhat of a success, I guess, from the vitamin A side to an extent, although, I mean, as you say, it's more complicated than just saying that was successfully scaled. But I guess thinking about other things that we're trying to scale, for example, treatment of wasting, and a whole host of other things. It would be interesting to know your thoughts on how we can utilize the mechanisms that are in place, and that's kind of, you know, our route in, if you like.
Stuart, did you want to address that question?
I don't know if Alison wants to respond. I think that's a key issue. The whole question about piggybacking, it relates very much, or we should think about capacity. I remember again working in India, and ICDS workers who integrated child development services in community level, village level, were being overloaded because they were being asked to be nutrition workers, they were being asked to be health workers, they were being asked to be agricultural extension workers, you know, and so the issue of capacity is absolutely key. And related to that, there was quite a bit of good work quite a few years ago on intensity when it comes to implementation, and that relates to personnel on the ground. So if we look at ratios between frontline worker whose responsibility is nutrition and head of population, that's one ratio. If we look at the ratio between frontline worker and his or her supervisor, is another ratio. And Thailand is one example where they kind of got those ratios right. India was unfortunately an example where they were so overloaded that the quality had completely gone. So piggybacking is, yeah, it sounds, you know, there is potential. This relates also to the issue, the earlier question about integration. Capacity has to be, you know, addressed in that. Yeah, so I think that is something we just need to keep our eyes on in terms of the feasibility of what we're expecting from certain personnel.
I think this is Alison. I would echo what Stuart has said. I think that the problem is not so much around the intention to piggyback, but it's more that the platform that you're piggybacking on also needs to be strengthened. And so adding one more thing to an existing platform without acknowledging what it takes to use that platform to deliver is a very big issue. Community health workers being that number one. I mean, health systems are devolving. Services are being pushed down to that community level. They're often, not very well trained, or in some cases are real traditional volunteers, and yet they're delivering 15 and 16 interventions at a household level that are really critical interventions that are not just curative care, but they're also counseling for nutrition. They're referring pregnant women, et cetera. So there's a lot of services that we are relying on the health system to do, but this does have to be coupled very seriously and led by governments around their initiative to strengthen the capacity of the health system to deliver as we add more to it. And this is increasingly becoming more and more of a problem with when we see, the the bulk of nutrition-specific interventions being delivered through the health system. Of course, there's other platforms that, education, ministries of education for adolescent nutrition, and also increasingly for children under 5. As urbanization increases, we're seeing, early childhood care centers as being places to reach children between the ages of 3 and 5 that are not seen through the health system. But these are just sort of emerging pieces. They're not necessarily widespread at this point. Thanks.
Thank you. And we probably have time for one more question before we move to next steps for the working group, if anyone has one.
I have one. Sorry, this is Emma Kent from 1000 Days. I'm just wondering, maybe for Alison, or maybe either of you actually, about target setting for coverage. How do you determine when something has reached scale? How do you determine your target?
Do you mean, is that in reference to the comment that I'd made at the beginning, saying that sort of the program target or the program goal is over 80% coverage? Is that related to that, or do you mean denominator? Yeah.
Yeah, I guess I'm wondering how you reach that number, and then how you gather the data to determine whether or not you've reached that number. On the advocacy side, it's such an important number, which is where I'm coming from, to give to policymakers. And so it'd be great to know just a little bit more about that.
Sure. So that number, this is one of those moments where it's an art and a science. And so it really began as there were efficacy trials that were done. Well, they weren't necessarily, anyway, I won't get stuck in those details. There were clinical trials that were done that showed where vitamin A supplementation coverage was at a certain level in the population, and the researchers observed a mortality reduction effect at a population level. And so when coverage was below 70%, there weren't sufficient children reached with vitamin A supplementation to see any sort of observed shift in mortality in the population. And so at one point, there was this direct sort of attempt to translate what was seen in clinical settings of coverage, where you saw an impact on a population level in those trials, and to translate that to a program setting, saying, what do we mean? What are we aiming for? So that if you're not reaching at least 70% of kids with 2 doses, then you're really not getting or moving towards the impact that one saw in an efficacy trial. And so that's where it was rooted. These sorts of things evolve over time. I mean, the universal coverage, the right of the individual child to receive vitamin A, means that every child who needs it should get it. So universal 100% coverage is your target, if you will. But programmatically, with around data and the challenges around population denominator and all these things, we're really we don't expect to see 100% coverage. A more realistic target setting is somewhere in the over 80%, means you're well on your way to delivering a program that you could expect some impact. So that's where that came from, and so I hope that helps. Certainly the monitoring piece. I mean, that data around vitamin A supplementation coverage, especially around 2-dose coverage, is the quality of data is variable across many countries.
Okay, thank you, Alison, and thank you, Stuart, for answering those questions and responding to those comments. And now, with just our remaining couple minutes, I'll hand it back to our co-lead Dylan to close the meeting.
Thank you very much, Chaitanya. I'll skip over if we had time permitted, a little bit of discussion on the literature scan activity concept note. But I do encourage you to share any feedback or ideas, or to help us focus and hone in on how this activity could be useful for the working group. But to conclude, just want to say that looking ahead, we will send out a follow-up feedback survey to be emailed shortly, either today or tomorrow, potentially with a recording of this presentation to all the members on the mailing list, not just the people that were in attendance today. We also want to remind you that if you're interested to send an email to the DevEx reporter by January 22nd, which is coming up early next week, we will send that email address again in the follow-up email, and you already received that email address earlier in the week as well, if you're interested in that. It'd be cool to have some engagement from the working group. And as well, we'd love to have any contributions or feedback on the terms of reference and literature scan concept within the next week or two. I think we're saying by January 31st would be very helpful to help guide the trajectory of this working group and its first tangible activity outside of the virtual meetings. We're tentatively planning the next quarterly virtual meeting for sometime in April and May. If you have any ideas for a theme or speakers or discussions that we should have to move forward with this nutrition scaling agenda, please feel free to add them into the feedback survey or by contacting Sakshi, our coordinator, or Chaitanya and myself. So in conclusion, just want to say a great big thank you to the speakers, Alison and Stuart. You guys were excellent, and I think the presentations melded nicely together. Thank you to all the participants for your contributions and being engaged in this new initiative. And thank you, Chaitanya, Sakshi, and thank you for the technology gods that were looking down on us today. I think it worked out. So we look forward to hearing from you virtually by email, as well as or through the feedback form and at our next virtual meeting. With that, I'll conclude this virtual meeting. Thank you and take care.